Okay, welcome. This is a presentation of Kaart Hart on CPVT. My name is Arthur Wilde. I'm working in the Amsterdam University Medical Center in the AMC, and the specific topic within the CPVT domain is ICD therapy. On a previous occasion, I have discussed the different treatment strategies in CPVT, which consist of lifestyle advices, beta-adrenoceptor blockade, flecainide, left sympathetic denervation, and ultimately ICD therapy. And that is the topic of this talk. The issue with ICD therapy is that there is a potential for pro-arrhythmia. And this patient was the first reported in 2008, where the patient, if you read this carefully, our patient died after probably initially receiving inappropriate ICD shocks for atrial fibrillation. So a patient with CPVT receives an inappropriate shock that is painful, that causes anger and fear, and that leads to an arrhythmic storm and ultimately death, as was the case in this particular patient. This is another example of ICD therapy not being effective. In this case, the sixth shock is ineffective, and unfortunately the arrhythmia stops at the very end of the registration. And this is another example, an arrhythmic storm induced by ICD discharge in a patient with CPVT. So there are, in the course of a few years, several examples now in the literature of inappropriate ICD shocks leading to arrhythmic storms. That means that ICD therapy might not be effective. ICD therapy may even be pro-arrhythmic. Obviously, randomized data on ICD therapy lack and will not be easy to obtain either. And you may wonder actually how many patients are out there that are not reported or just classified on the failed ICD therapy. Let's go into a little bit more detail. This is a study from Christina Miyake, published in 2013, on 24 patients, multi-center in a pediatric age group. 12 patients had an ICD because of secondary prevention, 6 associated with cardiac arrest. And in these 24 patients, 14 patients received 140 shocks in the follow-up duration. 10 patients received 75 appropriate shocks, all for ventricular fibrillation, and 43, that is 57%, had successful primary termination. 11 patients received 65 inappropriate shocks. In more detail, at the right side of the slides are the inappropriate shocks. The majority of them, or actually all of them, were because there was already spontaneous termination prior to ICD discharge. But in the appropriate shock site, there were 43 VF episodes which were successfully terminated, all of them by this shock. But the polymorphic VT, which is an arrhythmia that is not based on re-entry, none of them were unsuccessful terminated by the ICD. And also the bidirectional VT was not successfully terminated. Overall, in this series, there were 12 discharges in 5 patients. Almost 10% of total shocks resulted in a more malignant ventricular arrhythmia. And 4 of 14 patients, 30%, who received ICD therapy had an electrical storm event secondary to the ICD discharge. Importantly, in this series, the medication is not 100%. As you can see, even beta blocker is only received by 2/3 of the patients. Mixed antiarrhythmic drugs, which include flecainide, only in 1/3, and none of these patients had a left sympathectomy, had undergone a left sympathectomy. So the baseline therapy in this cohort is not optimal. Another series published by the Department of Cardiology from the Royal Brompton in London, the UK, is a single center experience with 13 patients in a mixed age group. All had an ICD for secondary prevention. And of these 13, 10 patients received 96 shocks, 30% of them inappropriate. And 10 patients had other ICD problems. And these other ICD problems are on this busy slide. Most of them were ineffective appropriate shocks or inappropriate shocks, lead failure, etc. But there were also in 2 patients very serious complications, infective endocarditis in 2 patients, and that led to ICD system extraction. In an overview of ICD therapy in patients with inherited arrhythmia syndromes from our group, it also turned out that ICD harm is the highest in the CPVT cohort, so the highest number of complications and the highest number of inappropriate shocks. This probably, the high complication rate probably relates to the young age of the patients. Thomas Rosten reviewed all the evidence in an international registry, and more than half of this cohort received an ICD despite concerns associated with ICD therapy, and these patients experience high rates of device-related complications, including electrical storm and inappropriate discharges. Now, from data from our own international CPVT registry, where the participating countries are colored in red here, so it's Canada, the US, a number of countries in Europe, Japan, Australia, and New Zealand, almost 1,200 cases as of November 2018. These are the number of patients in the individual countries, and the baseline characteristics of these patients are equal number of male and female, 1/3 is a proband and 2/3 are family members. And the symptoms in this cohort is no symptoms in almost a half of the patients, syncope in 1/3, aborted cardiac arrest in 172, and sudden death in 66. Now this registry is the basis for this paper published recently in the European Heart Journal on the effect of ICD therapy in previously undiagnosed patients with CPVT. The number of patients in this registry that presented with sudden cardiac arrest and were diagnosed with CPVT was 164. We had to exclude 28 because of short follow-up, because of missing essential information, because of not receiving guideline-directed therapy, and 2 patients were in a permanent vegetative state. So 136 individuals were the study cohort. 79 of them had an ICD, 57 were discharged without an ICD for various reasons. The groups were comparable with each other with the exception of a more aggressive pharmacological therapy in the group without ICD therapy. This is the Kaplan-Meier curve of sudden cardiac death in years from after clinical presentation. And as you can see, in the ICD group, there were 3 sudden cardiac deaths, whereas there were none in the no ICD group. From these 3 sudden deaths, there was 1 individual with a proarrhythmic effect by the ICD. 1 individual died at home without further data, and the 3rd individual died in an arrhythmic storm. So 1 individual here died because of ineffective ICD therapy. 1 individual died due to ICD therapy, and in 1 individual the circumstances are unknown. If you add to the Kaplan-Meier curve sudden cardiac arrest and appropriate ICD shocks, there is an overrepresentation in the ICD group, much more events in the ICD group compared to the non-ICD group, which you may consider obvious because appropriate ICD shocks is included in this graph. If you assume that every appropriate ICD shock is accompanied by syncope, you will balance the 2 groups if you add syncope to this graph. But even if you do so, there is still a much higher rate of events in the ICD group than in the non-ICD group, which essentially means, or probably means, that the ICD by itself is responsible for a number of shocks which are not present in the non-ICD group. ICD-related complications were huge, as in the other reported series. 25% had inappropriate shocks, and other device-related complications were present in almost 30% of patients, and they include lead malfunction or dislodgement, infection, cardiac perforation, Trittler syndrome, etc. So, in conclusion, ICD therapy in CPVT patients may be life-saving, but has a very high yield of inappropriate shocks, has a very high yield of ineffective shocks, has a high yield of other complications, and may be proarrhythmic, causing death. And a further conclusion is that the vast majority of patients is well controlled with beta blocker and/or flecainide, and left sympathectomy is a good option in those who are not. And I think the series show that you really have to avoid an ICD, and even avoid an ICD in patients who present with an out-of-hospital cardiac arrest prior to the diagnosis of CPVT. So these patients were not on optical medical therapy. No adherence is an issue, so if you are on optical medical therapy, you need to be sure that the patient is adherent to the therapy. Thank you very much for your attention.